Yeah.
Your turn.
Thanks for your great presentation. I have a difficult case, and I want to ask you, give me some suggestion. This patient is HER2 positive patient, and they will give them the new adjuvant chemotherapy, and she also she did not receive the PCR, and she received the ADC adjuvant treatment. But when the treatment, she got the ILD. So she stopped the treatment, and after just 6 months, she has the lung metastasis, and we do the biopsy. It showed that the ER 5% and the PR 15%, HER2 positive, and FISH is negative. And we also do the gene test, and she has the PI3KCA mutation. So for this patient, what's your suggestion for her? Thank you.
What antibody drug conjugate did she get postoperatively?
Yeah. What antibody are you get? T-DXd or T-DM1?
T-DXd.
T-DXd, William.
Okay, so obviously that drug had to be stopped in the presence of ILD. You wouldn't re-challenge her because presumably, she had X-ray changes, and if you're anything other than grade 1, we don't re-challenge. So now the question is, what could be considered? Well, if she doesn't have immediately threatening disease, as we were talking about earlier, and she does have a PI3 kinase mutation, you could consider fulvestrant capivasertib. There's no known significant risk to the lungs with that combination. T-DM1 could be considered but now she has not HER2 positive disease. It's HER2-low, right?
Yeah.
Yeah.
HER2 2 plus.
Yeah.
Yeah.
So that would
negative.
That would be less attractive. So I would probably, you're either going to give her some other form of chemotherapy, standard chemotherapy, or you're going to give her, target the PI3 kinase pathway. And I think if she doesn't have disease that you're immediately worried about, I would certainly try a doublet of endocrine therapy and capivasertib. It would spare her lungs. You're not going to affect them with that combination. You do have to worry, as I've mentioned, GI symptoms can occur. People can get a rash, they can get stomatitis, but not the lungs. So it's worth trying. And then, of course, if she breaks through that, then you'll have to reevaluate her thereafter, either chemotherapy or some other endocrine area. But I would think about a PI3 kinase inhibitor.
But she only has 5% ER positive.
Yeah.
Oh, I'm sorry. I'm sorry. But she was very strongly positive before, right?
Yeah.
Before, Chen, before is ER positive.
No. Before she is negative, ER PR positive. Negative.
I'm sorry. I missed that point. So she's not really a candidate for endocrine therapy at all.
Yeah.
So I would, in that circumstance, you're really talking, unfortunately, about chemotherapy. Because T-DM1, we don't have data with HER2-low disease. We don't want to re-challenge her with T-DXd. She's already at ILD. And she's not going to benefit from really any endocrine agent with an ER of 5%. It's probably not going to do anything. So I would be thinking about capecitabine or some other chemotherapy.
How about TROP2-ADC?
How about what?
TROP2-ADC.
Yeah, I mean, you can still get some ILD with it, but not any, it's not to the same. There's been ILD described with datopotamab. There's, few cases with sacituzumab. The other issue with, the ADCs in sequence is whatever comes second is not as effective as whatever came first. That's the data we have so far. So it could be considered. I would think about it cautiously. And there's even some who would say that, well, if you're going to give an ADC after an ADC, maybe you should try using something different in between. So there's a bit of a break between the two. So the other ADCs do not have the same degree of ILD that has been described as with T-DXd, but there have been cases described.
So you suggest the chemotherapy is better than using endocrine therapy?
Yeah, I wouldn't give her endocrine therapy, and I would think about a monotherapy chemotherapy. If she does well for a while, then I would potentially think about an ADC down the line.